1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
So, imagine a child who literally cannot feel the relief of a reward or, the sting of a punishment.
Right, where you ground them and they don't care at all.
Exactly. The behavior just doesn't change. You offer them like a massive reward, a new video game, a later curfew, and absolutely nothing happens.
Yeah, you pull every traditional behavioral lever you have as a caregiver or, as a clinician, and it's just nothing.
It's wild. And that's exactly what we're looking at today. Welcome to this deep dive. You, the listener, are staring down this massive stack of intense clinical literature on disruptive behavior disorders.
And it is a dense stack of literature, let me tell you.
Seriously.
Yeah.
So our mission today is to, cut through all that academic noise. I'm joined by our resident psychiatric nursing educator, and together we are going to act as your clinical guides.
That's right. We're taking all this theoretical textbook material and making it, intensely practical. Because disruptive behavior disorders are, they're some of the most challenging landscapes in clinical practice.
Because we like our medical diagnoses to be clean, right?
Exactly. I mean, a fractured femur shows up beautifully on an X-ray. A bacterial infection gives you a clear blood culture.
But when you step into the world of, neurodevelopment and behavioral dysregulation.
Yeah, the diagnostic picture gets incredibly muddy, which is why we are applying the 80-20 rule to this deep dive today.
The 80-20 rule. I love this framework.
It's essential. As a nursing student or a practicing healthcare professional, you don't need to memorize every single statistical anomaly in the literature.
Right. Nobody has the brain space for that.
No, absolutely not. So our objective is to extract the 20% of high-yield concepts that will provide 80% of the understanding you need. We're focusing relentlessly on clinical judgment, safe patient care, and the logic you need for, say, your NCLEX board exams.
So we're building a framework. We're going to cover the diagnosis, the pathophysiology, the risk factors, expected findings, and of course the priority nursing assessments and pharmacology.
Yeah, all the must-knows. But before we jump into specific diagnoses, we have to establish a baseline.
Okay, lay it on me.
Well, the literature gives us this overarching definition of what a disruptive behavior disorder actually is. It's essentially a fundamental problem with a person's ability to regulate their own emotions or behaviors.
And we're talking about persistent patterns here, right? Not just like a rough week at school.
Exactly. Enduring patterns involving anger, hostility, and aggression directed toward people or property. And that word regulate, that is the absolute hinge upon which all of these disorders swing.
Because emotional regulation is something most neurotypical adults just, take for granted.
Right. You feel a surge of frustration, your brain processes the context, and it applies a neurochemical break. So you choose a socially acceptable response.
But with these disorders, that regulatory mechanism is, what do the texts say? Structurally flawed, chemically starved, or just completely broken.
Perfectly said. And the source material maps out a very clear narrative arc for us to follow today. We're looking at a continuum of this regulatory failure.
Yeah, a continuum, starting with Oppositional Defiant Disorder, or ODD, right?
Yes, that's our entry point. And then we'll track how that simmering defiance can, unfortunately, escalate into the severe rights violations of conduct disorder.
And we'll also pivot to look at the explosive unpredictability of Intermittent Explosive Disorder, IED.
Right. And finally, we'll round it out with a look at some fringe impulse control issues, kleptomania and pyromania.
Okay, so let's anchor ourselves to that continuum concept first, because the sources are really clear that these disorders don't just exist in isolated little bubbles.
They absolutely don't. They exist on a spectrum of escalation. The clinical data shows a very strong link between oppositional defiant disorder and conduct disorder.
Like ODD is almost a stepping stone.
Basically, yeah. Many psychiatric researchers view ODD as a milder, early-stage variant of conduct disorder. And if conduct disorder is left untreated, it's the primary precursor to antisocial personality disorder in adulthood.
when I was reading that progression in the literature, the best way I could visualize it was like a volume dial of behavioral dysregulation.
Oh, I like that analogy.
Yeah, so ODD is the persistent grading background static. It's constant arguments, refusing to comply. It disrupts the household, but the damage is mostly just interpersonal friction.
Right. The damage is contained, mostly.
But then, if no one interrupts that trajectory, the dial turns up. Conduct disorder is the music blaring so loudly the speakers blow out. It's active, malicious, societal violation.
And then antisocial personality disorder in an adult?
The volume dials just rip off the console entirely.
That is a perfect clinical metaphor. And understanding that trajectory is exactly why early intervention is such a massive priority in nursing.
Because recognizing early onset ODD isn't just about, giving exhausted parents a break.
Not at all. It is a massive clinical safety red flag. The younger the child is, when they start showing severe oppositional behaviors, the higher the statistical probability that they will escalate, that the dial will keep turning up until they are actively violating the law.
So as a clinician, your priority assessment isn't just managing the defiance in the exam room.
Exactly. You are actively trying to interrupt a developmental trajectory. And this continuum concept, it is a huge target for board exams.
Oh, I bet NCLEX loves testing the boundaries between diagnoses.
They do, because ODD and conduct disorder look similar on the surface to an untrained eye, but they require vastly different clinical responses.
Right. So what's the line in the sand? How do exams usually test this?
The defining line comes down to the violation of societal norms and the basic rights of others. That is what separates conduct disorder from ODD.
So defiance versus violation.
Yes. ODD is hostile. It is uncooperative. But there is no cruelty to animals. There's no severe destruction of property or theft or deceitfulness. The exact moment those basic human or animal rights are violated.
Boom. The diagnosis upgrades to conduct disorder.
Exactly. So to really understand how to spot this early, let's unpack oppositional defiant disorder using our nursing model framework.
Let's do it. So starting with the diagnosis and condition. The clinical literature defines ODD as an enduring pattern of uncooperative, defiant, disobedient, and hostile behavior toward authority figures.
Yes, and as we just said, without major antisocial violations, it typically begins at home, usually directed at the parents.
But here's where I have to push back a bit. When I read uncooperative, defiant, and hostile behavior toward authority figures, my immediate thought was, wait, isn't that just a normal teenager?
I get that question constantly from parents bringing an adolescent in for an evaluation.
Right. I mean, adolescence is practically defined by pushing boundaries. So how do you, as a psychiatric nurse, separate standard teenage angst from a pathological disorder?
It's a critical distinction, and the literature addresses it by mapping out expected findings, contrasting normal adolescent behavior with abnormal pathological behavior.
Let's spend some real time here, because the table in the text was fascinating. Some of the acceptable behaviors would probably shock a lot of parents.
They really would. I mean, human development naturally involves periods of intense boundary testing. We expect it during the terrible twos, and we absolutely expect it during early adolescence as the child tries to form their own identity.
So let's look at a hypothetical 14-year-old. The text says it's totally normal for them to be wildly inconsistent. Sweet one day, slamming doors the next.
Completely normal.
And desperately eager for peer approval, to the point of ignoring their family or having an inability to delay gratification. If they want something, they want it right now.
Yes. And they might be highly ambivalent toward their parents, sometimes even escalating into active verbal aggression.
See, to a parent, yelling and slamming doors sounds like a nightmare. It sounds like a disorder.
It is exhausting, yes, but clinically speaking, those are just developmental growing pains as the frontal lobe continues to mature. The clinical threshold is only crossed when the behaviors cause tangible dysfunction in social, academic, or work situations.
Okay, so what are the actual red flags? What does the abnormal side of the ledger look like for expected findings?
Instead of just being unpredictable or moody, the abnormal behavior is persistently defiant, deeply negative, or actively depressed. And there's one subjective finding that really stands out.
Oh, the somatization, the frequent hypochondriacal complaints. That one blew my mind. Why would a defiant kid suddenly start complaining about mysterious illnesses?
It's a brilliant clinical observation. It speaks directly to the underlying pathophysiology. The child is experiencing intense internal dysregulation and anxiety, but they lack the psychological vocabulary to process it.
So the emotional distress has to find another exit.
Exactly. It translates into physical symptoms. They complain of chronic stomach aches or severe headaches with no underlying medical cause. Somatization is a major red flag that the child is overwhelmed by their own internal environment.
That makes so much sense.
Yeah.
And the objective findings extend to their social lives too, right?
Yes. While a normal teenager wants peer approval, a child with ODD often has a complete inability to maintain poor personal relationships with peers.
Because they're just too hostile.
Right. They can't maintain a single friendship. They can't function in a classroom without causing a major disruption. When the behavior isolates them like that, we are looking at true pathology.
So let's talk about that pathophysiology, the core problem in the brain, because the literature points out a physiological reality that really changes how you view these patients.
It does. It's not just a bad attitude.
Right. The text explicitly states that children with ODD have a reduced sensitivity to reward and punishment.
That phrase is the absolute crux of understanding ODD. Their neurobiology just doesn't process cause and effect the way a typical brain does. The neural pathways connecting a behavior to a consequence are impaired.
The analogy I kept coming back to was, it's like driving a car where the steering wheel is completely disconnected from the front tires.
Oh, that's a great way to look at it.
You can sit in the driver's seat, and you can turn the wheel as hard as you want. You apply a negative consequence grounding them, taking away the phone, or you offer a positive reward, a sticker chart, a trip to the movies.
But the car doesn't change direction.
Exactly. The behavior stays the same because the mechanical linkage just isn't functioning.
The disconnected steering wheel. That is exactly how you should conceptualize this. If a child's brain is insensitive to punishment, punitive measures don't act as a deterrent. And if they're insensitive to reward, positive reinforcement fails to motivate them.
And the text says this is compounded by impaired problem-solving abilities and a chronically low self-concept.
Right. They fundamentally lack competence in social situations, and their defiance is often just a maladaptive shield to cover up that incompetence.
Okay, so moving to nursing interventions. If traditional rewards and punishments don't work, how on earth do you treat a disconnected steering wheel? You can't just, send them to their room.
No, you can't. The absolute priority intervention is a highly structured protocol called parent management training.
Parent management training.
Yes. Because the child's internal regulatory system is impaired, the external environment, meaning the home, the parents, has to be rigorously and artificially structured to compensate.
The literature specifically says parents are trained to completely ignore maladaptive behavior, which sounds simple, but...
But it goes against every biological parental instinct.
Right. Ignoring a child who is actively hostile and screaming at you in your living room, that's agonizing.
It requires immense discipline. But from a behavioral standpoint, giving negative attention is still giving attention. When a parent yells back or argues, they're providing a reaction.
And to a dysregulated child, that reaction is a form of reinforcement.
Exactly. So parent management training teaches caregivers to withdraw attention entirely during defiant episodes. They ignore the bad, actively reward the positive with highly specific, tangible reinforcers, and apply unemotional, structured consequences for defiance every single time.
And for older kids, the text mentions the Coping Power Program.
Yes, as they hit adolescence, you have to involve them directly in cognitive restructuring. The Coping Power Program focuses on enhancing their personal strengths and teaching conscious techniques for problem solving. Combining that with parent management training for the caregivers yields the best clinical outcomes.
Speaking of the caregivers, let's talk about priority nursing assessments. The text explicitly flags the parent's mental health here.
It is a massive priority. The caregiver challenges are described as overwhelming, demanding, and unrelenting.
I mean, dealing with that level of defiance every day, I can't even imagine.
The risk of severe caregiver depression and burnout is incredibly high. And from a holistic nursing perspective, your priority assessment must include the parents.
Because they are essentially the primary treatment modality.
Precisely. If the parents are clinically depressed or completely burned out, the treatment plan collapses. Supporting the parents directly improves the outcomes for the child. If the parents go down, the ship sinks.
So what about pharmacology? Is there a must-know medication for ODD? Something to fix the steering wheel?
The short answer, and this is a vital point for NCLEX, is no. There are no FDA-approved medications to treat ODD behaviors directly. You cannot medicate defiance.
ODD rarely presents in a vacuum, right? The text talks about comorbidities.
Exactly. ODD is highly comorbid with ADHD, attention deficit hyperactivity disorder, as well as anxiety and mood disorders.
So that's where the meds come in.
Yes. If a patient has both ODD and ADHD, treating the ADHD with central nervous system stimulants like methylphenidate or amphetamine salts can dramatically decrease the severity of the ODD symptoms.
Because it improves their baseline attention and decreases impulsivity.
Right. It clears the neurological fog so the behavioral therapy can actually take effect.
Okay, so that's ODD. A slow-burning, persistent daily grind of defiance. But now we need to look at our next disorder. And this one isn't a slow burn at all.
No, this is a sudden, catastrophic failure of the brain's braking system.
Let's talk about Intermittent Explosive Disorder, or IED.
IED is characterized by repeated, spontaneous episodes of impulsive, aggressive, violent behavior, angry verbal outbursts, and the diagnostic time frame here is rapid. These explosive episodes usually last less than 30 minutes.
So if ODD is background static, IED is a 30-minute flashbang.
That is an accurate picture. And the most critical expected finding, the behavioral red flag, is that the intensity of the outburst is grossly, absurdly out of proportion to the stressor.
So like someone leaves a dirty dish in the sink and it triggers extreme rage.
Exactly. Physical injury to others, severe destruction of property, all with seemingly zero buildup.
But here's where the logic tripped me up. The literature says that after the episode subsides, these individuals feel intensely embarrassed, guilty, and remorseful.
They do. Deeply remorseful.
So if they possess the cognitive awareness to feel guilty, why can't they just stop themselves in the moment?
Because it's not a conscious choice. This is not a moral failing. To understand IED, we have to look at the pathophysiology. The text points to severe neurological imbalances, specifically a serotonin deficiency, plasma tryptophan depletion, and profound frontal lobe dysfunction.
Let's translate that into clinical mechanisms.
Yeah.
The frontal lobe handles impulse control and emotional regulation, right?
Yes. Think of the frontal lobe like the air brake system on a heavy semi-truck. Serotonin is the neurochemical air pressure that keeps those brakes functioning.
Okay. And tryptophan?
Tryptophan is an essential amino acid. It's the raw material your body uses to synthesize serotonin. If you have plasma tryptophan depletion, your brain is starving for the raw materials to make serotonin.
So the air pressure in your frontal lobe drops drastically.
Exactly. And when the air pressure drops, the brakes fail. So that minor stressor, the dirty dish in the sink, is a steep downward slope. The aggressive impulse is the massive truck. Without serotonin, the frontal lobe cannot apply the brakes, and the impulse just barrels down the hill.
It crushes whatever's in front of it. And the verbal or physical explosion happens before the conscious brain can even boot up.
Right. It's only after that massive neurochemical surge naturally subsides, usually within that 30-minute window, that the frontal lobe comes back online, assesses the wreckage, and generates that intense guilt.
Wow. And the text notes that childhood trauma and neglect are major risk factors here.
Yes, trauma physically alters the brain's threat response architecture. But there's another major clinical revelation here regarding physical safety. IED isn't just a psychiatric issue, it's a profound systemic physiological issue.
Yeah, this completely surprised me. The literature links IED to severe chronic physical outcomes: coronary heart disease, hypertension, stroke, diabetes. Why does a behavioral disorder destroy the cardiovascular system?
Think about what happens to the body during one of these violent episodes. The brain perceives a massive threat and triggers a full-blown fight-or-flight response.
So, massive dumps of cortisol and adrenaline.
Right. The sympathetic nervous system goes into extreme overdrive. Heart rate spikes, blood vessels constrict, blood pressure skyrockets. Now imagine putting your cardiovascular system through that violent stress test multiple times a month for years.
The chronic wear and tear would just shred your system from the inside out.
Exactly. Constant endothelial damage to the blood vessels, metabolic disruption from the cortisol. As a nurse, your priority assessment for a patient with IED must include a thorough cardiovascular workup.
So how do we treat the failing air brakes? Let's talk must-know medications.
Pharmacology is central to managing IED, and it's highly testable. The goal is to correct the serotonin deficiency. So first line is SSRI antidepressants, specifically fluoxetine Prozac.
Because SSRIs block the reabsorption of serotonin, keeping more available in the synaptic cleft. You're pumping more air into the brake lines.
Exactly. We also use mood stabilizers like lithium, which alters sodium transport and has a pronounced anti-aggressive effect. But the literature also highlights anticonvulsant mood stabilizers. Valproic acid, which is Depakote, phenytoin or Dilantin, topiramate and oxcarbazepine.
Wait, those are seizure medications.
Yeah.
How does an anticonvulsant stop an aggressive behavioral outburst?
Think about what a seizure actually is. It's a sudden, violent, uncontrolled electrical discharge in the brain. An IED outburst is functionally similar to a limbic seizure. It's a sudden loss of electrical and neurochemical control.
Oh, that makes sense. So they stabilize the membrane.
Yes. Anticonvulsants quiet the electrical activity, often by enhancing GABA, which is inhibitory, or by blocking sodium channels. They raise the threshold required to trigger an explosion.
So if we're starting a patient on fluoxetine or valproic acid, what is the priority nursing education piece?
This is a critical exam trap. You must educate the patient and family that these medications reduce the frequency and intensity of aggressive impulses, but they do not eliminate the outbursts entirely.
Because if they think the pill is a magical cure,
The first time they have a breakthrough episode, they'll assume the drug is useless, become non-compliant, and stop taking it. The nursing priority is managing expectations and pairing the meds with cognitive behavioral therapy and anger management. The medication just gives them that crucial millisecond of braking power so they can apply their coping skills.
that is such a vital distinction. All right, so we've been discussing outbursts fueled by sudden rage. But the text takes a fascinating detour into behaviors fueled by an internal psychological itch.
Ah, yes. The fringe impulse control disorders, kleptomania and pyromania.
Let's start with kleptomania. It's the impulsive, repetitive theft of items. But the diagnostic distinction is that the items aren't needed for personal use and they aren't stolen for money.
Right. It's not about pawning a watch for cash. It operates on a tension cycle. The patient experiences high anxiety right before the theft. The act of stealing provides immense relief or exhilaration.
And once the tension breaks, they often just discard or hide the item. The reward is the neurochemical release, not the object.
Exactly. And demographically, kleptomania is vastly more common in females, which contrasts with ODD and IED, which lean heavily male.
And the other disorder in this category is pyromania, repeated, intentional fire setting.
Yes. And much like kleptomania, the motivation defines the pathology. They have a deep fascination with fire, and setting it provides tension relief. There is no monetary gain, no revenge motive, and they aren't concealing a crime.
But thinking about nursing care, where do these pyromania patients actually end up? Because arson is a major crime. Are we treating them on the site floor?
The reality, and the literature is sobering here, is that pyromania as a primary psychiatric diagnosis is exceedingly rare in clinical settings. Because the behaviors are illegal, these individuals usually end up absorbed by the criminal justice system long before they reach the mental health system.
Which provides a dark but perfect bridge back to the ultimate escalation of our original continuum. Let's talk about conduct disorder.
Conduct disorder is the most severe disruptive behavior disorder we're covering. It's defined by a persistent pattern of behavior that violates societal norms, rules, laws, and the basic rights of others.
Bringing back our earlier analogy, if ODD is refusing to do homework and yelling at mom, conduct disorder is setting the school on fire and assaulting a classmate with a weapon.
Precisely. The shift is from defying authority to actively, maliciously violating the physical and emotional safety of others.
So how do nursing students get tested on this escalation?
In any clinical scenario, if the prompt features cruelty to animals, initiating physical fights with weapons, destroying property, or engaging in deceitfulness or theft, the diagnostic arrow points directly to conduct disorder.
You cannot choose ODD if human or animal rights are being violated.
Absolutely not. That is the hard boundary. And the nursing priority shifts dramatically here. With ODD, we focused on parent management training. With conduct disorder, the absolute highest nursing priority is milieu safety, protecting the patient and others from immediate physical harm. You are heavily focused on de-escalation and crisis intervention.
Okay, we have thoroughly dissected this literature. We've mapped the continuum, the neurobiology, the pharmacology. Now it is time for the 80-20 rule synthesis. I want a rapid-fire, mentor-style breakdown of the must-knows pulled directly from this material.
Let's lock it in. We'll start with the must-know disorders. Number 1, oppositional defiant disorder. Clinically, this is persistent defiance without major rights violations. The underlying pathophysiology is a reduced sensitivity to reward and punishment. The primary intervention is parent management training, not medication.
Number 2.
Intermittent explosive disorder. Disproportionate 30-minute explosive episodes of rage, followed by deep remorse. The core problem is a failure of the frontal lobe's air brakes, driven by serotonin deficiency and tryptophan depletion.
And number 3 is conduct disorder.
Yes. the severe escalation. The defining testable trait is the active violation of societal norms and the basic rights of others, cruelty and violence.
Okay, let's move to the must-know pharmacology.
For ODD, remember there are no specific FDA-approved meds for defiance. You treat the comorbid conditions, like using CNS stimulants for underlying ADHD.
And for IED?
For IED, memorize the serotonin and membrane stabilization connection. You use SSRIs like fluoxetine to increase serotonin. You use lithium for anti-aggressive properties, and anticonvulsants valproic acid, phenytoin to quiet the limbic system. And the most critical education point, teach the patient that these drugs reduce outbursts, they do not cure them.
What about must-know safety risks and priority assessments?
Never ignore the systemic physical toll of IED. These patients are at severe risk for cardiovascular events like strokes and coronary heart disease due to chronic sympathetic overdrive.
And for ODD, the safety risk is the family.
Yes, severe caregiver depression and burnout. If the parents collapse under the strain, the entire treatment fails.
Finally, the must-know exam traps.
Do not confuse normal adolescent development like moodiness and a desire for peer approval with clinical pathology. Pathology involves severe social dysfunction or somatic hypochondriacal complaints. And remember the diagnostic boundary. ODD does not cross into violating the rights of others. Conduct disorder does.
That is the 20% of the material that secures 80% of your clinical understanding. But as we wrap up, I want to leave you with a final provocative thought.
Alrighty.
Something that really stuck with me. The literature states that treating ODD relies almost exclusively on parent management training, right? Ignoring the bad, rewarding the good.
Right.
But that same literature told us that the pathophysiology of ODD is a neurobiological reduced sensitivity to reward and punishment.
It is a profound clinical paradox.
It truly is. If a child has a neurological disconnect where their brain literally cannot process the chemical feedback of cause and effect, how sustainable is a primary treatment model that relies entirely on behavioral conditioning?
It really makes you wonder about the upper limits of traditional behavioral therapy.
Exactly. It pushes us as clinicians to look deeper into trauma-informed care and maybe toward future neurochemical interventions that might actually, repair the steering wheel rather than just forcing the parents to endlessly yell at the tires.
It is a brilliant question to end on. Questioning the established modalities is exactly the kind of critical thinking that moves psychiatric nursing forward.
We encourage you to take these high-yield insights directly to your clinical practice and your board exams. Thank you for joining us on this deep dive. Keep questioning the clinical logic and keep navigating those murky diagnostic waters.